Welcome to the ATC HSSC online training series. In this session, shock management. You'll learn to recognize shock early, stabilize the patient using a structured approach, treat while you search for the cause, and communicate clearly for rapid escalation. What is shock? Shock means the organs aren't receiving enough oxygen and nutrients. It progresses quickly. Assume instability and intervene immediately while you call for help. Early red flags. Watch for falling blood pressure, a racing pulse, cool, clammy skin, confusion or restlessness, and reduced urine output. These signs together should trigger urgent action rather than watchful waiting. First minute. C, A, B, C, D, E. Announce that you're calling for help and start ABCDE. Secure the airway, check breathing and oxygenation, and then focus hard on circulation, blood pressure, pulses, and visible bleeding. Do a brief neurocheck and expose only as needed to find rashes, wounds, or line issues. Oxygen and IV/IO access. Give oxygen if the patient is hypoxic. Establish 2 large-bore IV lines, or IO if IV isn't possible. Send baseline bloods as per protocol and prevent heat loss. Hypothermia worsens clotting and outcomes. Classify while treating. As you stabilize, categorize likely shock. Hypovolemic from fluid or blood loss, distributive from sepsis or anaphylaxis, cardiogenic from pump failure, or obstructive from blockages like tension pneumothorax or massive PE. This guides your next moves. Immediate actions by type. For hypovolemia, start balanced crystalloid and stop the bleeding. In suspected sepsis, begin fluids and follow your sepsis bundle promptly. For anaphylaxis, give intramuscular adrenaline first and support airway and breathing. Cardiogenic or obstructive shock needs urgent senior input for targeted therapies. Fluids and reassessment. After each bolus, reassess within minutes. Mental state, skin perfusion, blood pressure, lung sounds, and urine output. Adjust the plan quickly to avoid both fluid overload and under-resuscitation. Vasopressors, inotropes, trained settings. If hypotension persists despite fluids, start vasopressors or inotropes per protocol, preferably through central access, with continuous monitoring. Titrate to targets while you keep searching for and treating the cause. Adjuncts and investigations. Use ECG and chest imaging or bedside ultrasound to refine the diagnosis. In suspected sepsis, draw cultures early and move towards source control. Drain an abscess, remove an infected line, or start antibiotics as directed. Documentation and handover. Record times, vitals.trends, fluids, medications, and the patient's response. Handoff with a focused SBAR so the receiving team knows the current status and the immediate plan. Common errors to avoid. Don't delay calling for help. Don't keep giving fluids blindly without reassessment. Don't forget to look for the underlying cause. Shock is dynamic. Your treatment must be too. Quick SBAR example.
55-year-old, hypotensive and confused. Fever and dysuria suggests sepsis. Blood pressure 82/50. Heart rate 128. Elevated lactate. Request fluids now, initiate sepsis bundle and ICU review. Short, clear, and sets the next actions.
Mastering proper shock recognition and early management is essential for maintaining adequate tissue perfusion and preventing organ failure. Early recognition, rapid stabilization, timely intervention, and adherence to emergency protocols improve patient outcomes. For more practical clinical videos and learning content, Visit www.healthcare-eskilling.com. Thank you.